about today is basic principle and introduction of M mode and two-dimensional echocardiography. The most important part of this particular talk is we have to understand the basics of imaging. What exactly we are going to talk about it. And may I request everybody to please silent their mic, because once your mic is open, it's going to make a lot of disturbance for the other persons as well. Why we need echo for a cardiologist and physician in clinical practice? This is a slide which is almost 10 years down the line. The answer is, a very important answer to this particular issue is, in midnight, patient presenting with breathlessness, and very common scenario for the persons who are working in emergency room. We want to know what is the cause of this breathlessness. Is it respiratory, cardiac, or metabolic? And if it's cardiac, is systolic or diastolic? If it's respiratory, what is the PA pressure? Is the patient suffering from pulmonary embolism? Or it could be just metabolic patient presenting with breathlessness. Who can give you all this answer? Echocardiography along with other modalities. And those people who are working in tertiary care hospital, all of us understand, whenever the person comes with the breathlessness, we have SOB protocols, and echo is one of them along with other things. Patient presenting with chest pain, ambiguous ECGs, possibly echo. Patient in shock, you want to know whether it's hypovolemic, euvolemic, or IVC plethora is present. So that who can tell you all these kind of things? Echocardiography. You heard a murmur in the heart. You want to know the cause. In your hospital, patient admitted with stroke. What is the cause of this stroke? Is it atheroembolic or atherothrombotic? And on last is the preoperative evaluation non-cardiac surgery. In this medical legal era, every person who has got some cardiac illness, we want to have to classify them whether these persons carry some risk during a cardiac surgery or not. And this list, mine, is going on, and every field virtually is talking of echocardiography. So what physician was doing earlier? He was referring these cases to cardiologists. And unfortunately, our elder senior colleague of DM cardiology who are busy in intervention do not have a time for echo. Who can take up this challenge? Obviously, the challenge can be taken up by physicians, intensivists, pulmonologists, critical care specialists, anesthesiologists who are working in this area. So we said, can't we do it by self? And that's where the lie of echocardiography comes. If you look at this echocardiography, when the echocardiography got originated, we started talking of M-mode echocardiography. And now in 2022, what it 2022, only two dimensions echocardiography to begin with. And that's what the changes happened in last 40 years of echocardiography. So we are going to talk about important definitions, selection of transducer, position of patients, placement of transducer, two dimensions echocardiography, and finally comes the M mode, which is derived from two dimensions echocardiography. First word is resolution and second word is penetration. When we talk of a selection of a transducer, we talk of resolution and penetration. What is resolution? Resolution is the ability to identify two different objects lying close to each other. And the best example I always give for this is, if a car is approaching to you on a highway, the two headlights, they look like a blob. When they come closer to you, they start separating out. And when they're standing right in front of you, you can say, what is the two headlights are? What is their size? What is the difference between these two headlights? And finally, what is the texture of these two headlights are? So the resolution of a car which is standing close to by is the best resolution, or highest resolution versus the resolution when the car was far away from you, when the image looked like a blob. On the other hand, penetration. What is penetration? Penetration is depth. If I'm scanning a person or a child or a neonate who hardly any chest muscle mass, we don't need any penetration, versus an adult population who has got a significant muscle mass in between the point of interrogation and the point of evaluation. And that's what the word penetration is. Based on this resolution, based on this penetration, we talk of transducer. And what do we talk of transducer is? We talk of frequency, and this frequency leads to evaluation, what kind of a transducer which we should use in our clinical practice. Lower frequency transducer is like 2.5. Higher frequency transducer means 10 megahertz transducer. Lower frequency transducer, they have a better penetration, good Doppler studies, but poor near resolutions. On the other hand, higher frequency transducer, they have a poor penetration, higher definition of cardiac images, but poor Doppler studies. So in adult, what we are using lower frequency, but in pediatric or neonatal, we are using higher frequencies. But the problem both lies with adult, like we do not have a good near resolution. On the other hand, in high frequency transducer, we do not have a good Doppler studies. So these are two lacunas which we encounter with these kind of a transducers. Then comes what kind of a transducer or what frequency we use in adult, pediatric, neonate. In adult, we use 2 to 2.5, pediatric 3.5 to 5, neonate 7.5 to 10. And to take care of these two lacunas, what was poor near resolution and poor Doppler studies, now we have got a wide band transducers or harmonic transducer. What do you mean by wide band or harmonic transducer is? That is an important thing now. Issue is when we are using a transducer of 2 megahertz, it sends an impulse beat at 2 and receives back at 4. So almost twice the frequency. So what does it do? It's doing a penetration at 2 megahertz for deeper structure. For 4 megahertz is imaging a nearer structures. So what happens? The better penetration is present by 2 megahertz, good Doppler studies by 2 megahertz, but 4 megahertz is taking care of a poor near resolution. So the near resolution also becomes good, and that's what is known as wide band transducer. And if I have to buy a machine today, if you are buying a machine today, the only way is to buy a wide band transducer. There's no rule of buying a non-harmonic or linear phase array transducer without. Last come 3D transducers. Then come footprints. Many of you must have seen we are using a large abdominal transducer for echocardiography. The footprint is very big. It cannot insinuate in between intercostal space. So we need to have a footprint which is able to insinuate in between the intercostal spaces. The footprint is pretty small for pediatric population, reasonable for adult population, but not as big as abdominal transducer. Based on this frequency, penetration and depth, we have these kind of a transducer available in the market. Some are obsolete, some are available. We started with single oscillating crystal transducer. So single crystal was oscillating at a very high speed. Then came rotating transducer. Then came annular phase array transducer. And then came linear phase array transducer. All these array transducer, they are phased away completely. What we are dealing as on today is we are taking of broadband linear phase array transducer, which we call them as harmonic transducers. Or we can have multi-planar broadband linear phase array transducer, or we can have a 3 dimensions transducer. Either of these two, whichever you can afford. Here is an example for linear versus linear broadband phase array transducer. This is linear transducer, and this is linear broadband phase array transducers. So look at there are two range of a crystal which are aligned perpendicular to each other and giving rise to multiple beams in one go. This is curvilinear transducer, which we use for pediatric population. This is linear transducer, which we use for peripheral vascular Doppler study. This is phase array adult transducer, which we use for adult echocardiography purpose. And they are based on this matrix principle, where the crystals are aligned both in long axis as well as short axis, and leading to a beam formation at one particular point. And this beam formation really helps us in focusing certain structure when we need to have. So here is example for 3 dimensions echocardiography. Look, this is linear broadband multi-planar phase array transducer. In one go, we can get 4-chamber, 3-chamber, and a 2-chamber view. And at the same time, we can drive a 3 dimensions echo image out of this. And this is a 3 dimensions echo image, which appears to be like as if the heart is contracting. That's how it happens. And these kind of a transducer, when we happen to see these kind of a transducer, they are very useful in day-to-day practice. Allow me a second. Somehow that system. So how that looks like linear broadband multiplanar phase array transducer. So you can see the volume of blood, which is in diastole as well as systole. This is 3 dimensions phase array transducer.
So we can't see your screen.
You can't see a screen? I'm sorry. Can you see the screen now?
Yes, sir.
So this is 3 dimensions transducer, which has got both long axis, short axis, as well as depth for a transducers. Then comes planes of the heart. Look, whenever we are going to talk about the heart, we are going to talk about long axis. This is the long axis of the heart. This is a short axis of the heart. And this is the 4-chamber plane of the heart. So if I cut my heart in short axis, if you look at it, what do I cut? I'll cut wherever, either it's mitral valve, where I'm cutting across the short axis, or it could be aorta, where I'm cutting at the short axis. If I'm doing a long axis, I'm cutting across LV, LA, and the aorta. So when we talk of our axis, this is either a long axis or a short axis or a 4-chamber planes. This is a pictorial one. This is a 3-dimensional picture of an heart. If I'm doing a long axis, this is a cut of a long axis S. If I'm doing a short axis, this is a cut of a short axis S. And if I'm doing a 4-chamber plane, this is a cut 4-chamber plane. So when we talk of a heart, we'll be talking of long, short, and a 4-chamber planes. Then what should be the position of a patient? In which position patient should lie? The commonest position where the patient lies is always left lateral decubitus position. Why? This brings us more the heart closer to your chest. Then second is, what are the places where should keep the transducer? The places, parasternal long axis view, left plaque, parasternal region. Then comes apical region. Then comes subcostal region. Then comes suprasternal region and right parasternal region. This is for adult population. Now in reverse happens in pediatric population. We start with subcostal region to identify the structures to label as morphological RA or morphological LA. So at this present moment, we talk of a left parasternal region. What are these windows? This is left parasternal window is left third intercostal space, close to sternum. Apical fifth intercostal space is apical window. Subcostal in Zephyr process. Suprasternal in suprasternal fossa, and right second intercostal space for right parasternal window. We'll be talking about this again and again. At your level, just remember left third intercostal space adjacent to sternum is a parasternal window. Apical at apex, everybody knows about the apex. Subcostal, everybody knows subcostal. Suprasternal fossa, everybody knows about suprasternal fossa. Once we put a transducer in parasternal region, what do we get? We get parasternal long axis view, short axis view, RV inflow view, and a ductal view. In apical window, what we get? 4-chamber, 2-chamber, 3-chamber, and 5-chamber view. Subcostal, 4-chamber, short axis, and IVC view, and suprasternal ascending and descending aorta. At the present moment, it must be looking very elaborate for all of you. How many views? 4, 5, 4 and 4, 8, 11, 14 views for doing echocardiography. My God. But they're number ones. But in 10, when you start looking at them, they'll not be big ones. Left third intercostal space, parasternal window. What do? We do an index marker at 11 o'clock position. Now, first question come for a new batch is, what is index marker? If any one of you seen a transducer, there is a mark on the transducer, or there's a light which is being seen on a transducer. That light or a mark is known as index marker. If this patient chest is taken as a watch, this is 12 o'clock position, this is 9 o'clock position, this is 3 o'clock, 6 o'clock position, this is 3 o'clock position. If I put a wall on this particular chest, this becomes 11 o'clock position. If I put my transducer at left second intercostal space with the index marker at 11 o'clock position, so what I'm doing a long axis view. Let me go back to my previous image, if you happen to remember. Look, this is our heart. Put in a watch on top of it. This is 12, this is 9. And this is what I'm cutting my index by keeping a transducer in Psax window. I'm going to do a parasternal long axis view with index marker at 11 o'clock position. So if this is the index marker over here, it is facing 11 o'clock position. So this index marker at 11 o'clock position, what do we get? What we get is parasternal long axis view. And what that parasternal long axis view is? Here is a parasternal long axis view. Look at this view. It has been labeled for you. It's not that it's not been labeled. It has been labeled for you. And once you label this view for you is, we can identify structure very, very easily. What are those structures are? This is the point of contact of a transducer. First structure is RV free wall, then RV, then anterior aortic root, posterior aortic root, right coronary cusp, non-coronary cusp. This is anterior interventricular septum or anterior septum, which is in continuation with anterior aortic root. Posterior aortic root is in continuation with AML. This is whole part is LA. LA posterior wall or free wall is in continuation with LV posterior wall and the posterior mitral leaflets. There is descending aorta. And many of you often ask, what is the importance of doing echocardiography in all views? Well, I'll tell you one important thing. If I'm doing the echo only in 4-chamber view and then expecting my echo is over, possibly we are doing a mistake or big blunder. Why so? In this particular window, suppose we have got anterior wall MI, and all of you are must be a big legends in your field of medicine and cardiology. When a patient comes with anterior wall MI, what do we look for? We look for ST elevation in V1 to V4. Can we say that this ST elevation is in mid LAD, proximal LAD, or distal LAD? With ECG, I'm sure many of us will make multiple comments. Some will say yes, some say no, some say can't. But if you are doing an echocardiography in this anterior wall MI, you look at this basal anterior septum, mid anterior septum, you can decide whether this is a proximal LAD, mid LAD, or a distal LAD. How? The answer comes, if you have this basal anterior septum which is involved, this is supplied by D1 branch of LAD. What does it mean by? If my D1 branch is involved, it means I'm dealing with proximal LAD lesion. If the septum is spared, anterior septum is spared, it means what? I'm dealing with a lesion which is distal to D1 branch of LAD. So possibly I'm dealing with not proximal LAD lesion, I'm dealing with mid LAD lesion. Diagnosis. Now, once I see a proximal LAD lesion, what do? Obviously, the places where we do not have intervention facilities, thrombolysis is the therapy of choice. But places where we have an intervention facility, if you deal with a proximal LAD lesion or left LAD lesion, believe my words, majority of these thrombolysis, they are failures. So why we should be ready in case we are doing a thrombolysis, we should be ready for thrombolytic failure. And if we have a good intervention facilities, if I would be the treating physician, and if I have this proximal LAD lesion, I would like to subject this patient for intervention rather than trying for thrombolysis. That is one take-home message. Now look at this mitral wall leaflets. This posterior wall does not have a papillary muscle. Suppose you happen to see a patient with significant mitral regurgitation. Patient comes with dyspnea on exertion. He talks of a mild chest pain. And with mild exercises, if this MR increases, it means we are dealing with ischemic papillary muscles. Who else can you give this information? Echocardiography, none other than that. Let's move on to this RV RA inflow view. If I move by transducer from left third intercostal space, this is the index marker at third intercostal space. Index marker facing 11 o'clock position. Now let this transducer footprint start looking towards mediastinum. If I tilt this transducer to right side, so the footprint start looking towards medially. So what is looking forward? Here is RA, here is RV. So what do we get? We get RV, RA inflow view. Here is RA, here is RV. And if you had put my cursor line across this particular phenomena, what do I get? I get a very good tricuspid regurgitation gradient. And this tricuspid regurgitation gradient is helpful for what? For calculating pulmonary artery pressures. And all of you can understand, when we have a lesion either on right side or left side, we need to have assessed the right-sided functions along with pressures. And this is one of the common window which we utilize every day in our practice for assessment of pulmonary artery pressures. Now from this parasternal long axis view over here, this is 11 o'clock position, tilting a transducer, and the footprint looking toward mediastinum, we are getting RV-RA inflow view. Now we rotate this transducer to 90 degree. What exactly? The same position, and the index markers start facing from 11 o'clock position to 2 o'clock position. And the footprint is almost perpendicular at the same place. And once the footprint is perpendicular at the same place, what do we get? We get aorta in the center, then RV on top. This is RVOT. This is RV. This is tricuspid valve. This is RA. This is LA. This is interatrial septum. And here is a pulmonic artery which bifurcates to right and left. Now, remember and go back to your old golden days of medical college. What were those golden days? We used to have a surface marking for echocardiography. What was the surface marking? Our teacher used to tell us, look, how do I look at my various subjects or various parts of my body? We used to surface mark everything on a patient's body or our own body. When we talk of a surface marking, then we used to say, here is my third intercostal space, here is my mitral valve. So same thing is lying over here. Here is a third intercostal space and we have an index marker at 11 o'clock position. Suppose I rotate this index marker to 2 o'clock position and pointing at the same thing is, I'm just cutting across this papillary muscle. Mitral valve, not papillary muscle. If my footprint is looking towards aorta, I'll make parasternal short axis view at aorta. If my footprint is almost perpendicular, I'll making mitral view. If my footprint has start looking toward my left hip, then possibly I'm looking at papillary muscle and then finally the apex. And once we do this from a parasternal long axis view, we go to RV or inflow view, then we go to aorta. And as we tilt back or look, let the footprint start looking from a right shoulder to a left hip, first thing we come across is mitral valve. Then we come across papillary muscles, and then we come across the apex. These four images, they make a lot of difference when we are talking about these particular views. Now, it may be a little difficult for all of you, like how to really make views. And when after 3 weeks down the line, when we have done with this online presentation, we will go live and show you how to make these views so that you can appreciate, look, these views are important and they can be made very easily with day-to-day practice. This is parasternal short axis view at aorta. What does this view tells us? This is the view tells us the aortic valve has got 3 cusps. This is the right coronary cusp where the right coronary artery arises. This is left coronary cusp where the left coronary artery arises. And this is a non-coronary cusp because God has given only left and right coronary artery. And no artery has been given in this particular cusp. We call them as non-coronary cusps. On top of this is pulmonic artery. This is pulmonic valve. And this is the only view where we can see a pulmonic valve. This pulmonic artery bifurcates to right and left pulmonic artery. And here's a descending aorta. If you have a PDA, the blood will flow from descending aorta to pulmonic artery, which can be easily seen over here. We'll show you that examples later on. Then we have a tricuspid valve. If you have a drive, a tricuspid regurgitation, we can look at a TR jet velocity. And at this particular point, we can look for a forward flow of a tricuspid valve. Similarly, this is interatrial septum. In the same view, we can look for interatrial septal defects. So that's how in parasternal long axis view, we have multiple answers for looking for parasternal long axis view. Then comes parasternal short axis view at mitral valve level. And if you happen to look very carefully at this mitral valve level, what is most important part for any mitral stenosis or mitral valve area? The important part is mitral and valve area by planimetry. No other view can give you this particular finding except this planimetry view by mitral area on this particular window. And if you happen to freeze this window over here, you can see that we can look at all commissures and everything of a patient's. Here is the medial commissure, here is a lateral commissure. And we can planimetrize the whole of this mitral valve area to derive the mitral valve area. And whatever the valvular lesion is it mitral stenosis, mitral regurgitation, MS with AR, MS with AS, MS with any other lesion, if you have to come to final conclusion, the severity of mitral valve lesion, this is the one window where we look for mitral valve stenosis is there or not there. On top of that, we want to do a planimetry. Apart from planimetry, we want to take up these patients for interventions. And persons who have been to this field, they know what do we look for interventions. We want to look the commissure. Are these commissure lateral or medial commissure? Are they calcified? And if they're not calcified, then only we do commissurotomy by balloon. And those people who are doing it already, those people who understand already what we split, we don't split mitral valve, we split commissures of a mitral valve. And if they're not calcified, our results are very good. And if they are calcified, our results are horrible. So parasternal short axis view gives us the most important thing is mitral valve area. Then comes next papillary muscles, parasternal short axis view at papillary muscles. Importance, we try to realize there are two papillary muscle, lateral and medial. And number of times we see in our lab, single papillary muscle, parachute mitral valve. On top of this, it gives you what kind of an interventricular septum we are dealing with. If you look at this septum carefully, with every bulb, this septum becomes sickle shaped. What does it mean by? It means by LV pressure is more than RV pressures. Suppose your RV pressures have gone up, this septum will become flat. If your RV pressure are more than LV pressure, with every systolic contraction, this interventricular septum will bulge towards LV. So looking at the septum itself, you can jolly well say whether this patient has got an elevated PA pressure or not. That is qualitative evaluation. I'm not saying quantitative evaluations. So every image tells you, like every हर चीज बोलती है. So every echo की image बोलती है. Look, there's something lying in this image. So that's what this image tells you. Look at this septum. It's rounded. It's sickle shaped. RV pressure are much less than LV pressure. And if suppose the septum is flat, it bulges towards LV, we can always tell without anything what is my RV pressure are. LV pressure we can derive from aorta or blood pressure. Suppose my LV pressure is 120. If this septum bulges towards LV during systole, my RV pressures are more than 120 millimeters of mercury. Very simple, straightforward way of calculating hemodynamics by looking at this particular view. We can go back and look at TR-jet gradients to evaluate my RV pressures. But in nutshell, this image tells you, look, my RV, how much is my RV pressures are. Next comes papillary muscles. This papillary muscles number of times tells you what is my apical contraction is. Is it hypokinetic or not kinetic? Normokinetic, and that's what is being told by this papillary parasternal short axis view at apex. If I look at all these windows together, so let me recapitulate what are the views which we started looking at. First parasternal window is left third intercostal space. Index marker at 11 o'clock position. What do we drive? We drive Psax view. Psax view is consisting of parasternal short long axis view, then RV RA inflow view, and the 4 parasternal short axis view at aorta, mitral valve, papillary muscle, and apex. And all these views have got certain definite importance. Let me show one by one all views in your presence again. This is parasternal long axis view. Then comes RV RA inflow view. Then comes parasternal short axis view at aorta. Then comes mitral valve. Then comes papillary muscle, and finally the apex. And this 6 views, one will become proficient. It will not take less than 1 minute to look, see, and analyze these 6 views for our day-to-day practice. Now let's move from parasternal long axis view to apical positions. We were dealing with long axis and short axis. Now let me go back to my original slide. first, second slides, when we talk of the planes, and this is the 3-diagram picture of planes. I did a long axis view like this. I did a long axis view like short axis view like this. I use my transducer in left third intercostal space, close to sternum. Now I move my transducer to apical window, and the best point for apical window is where the apex lies, because this is an axis of the heart. Normal axis is plus 45 degree. The axis could be 100 plus in hypertension, or minus 10 or minus 20 in hypertension. The axis could be 90 degree in COPD. So we have to look at an axis by feeling the impulse beat but in the apex with our left hand, and wherever the apex beat is, just put a transducer out there to look for apical window. But the crux is we have to be as parallel to the heart as possible. We cannot be perpendicular to the heart. So we have to just insinuate our transducer along the line of the heart, and this is the line of the heart, which you can see like as if we are slicing the heart in a slice fashion. Look at the bread. If you look at the bread, bread has been transected in short axis view. You slice the bread in long axis view so that the whole loaf split over into two parts, and that's what the 4-chamber plane is. Once we go to apical 4-chamber view, where do we put a transducer? We put a transducer in third intercostal. From second intercostal space, we put a transducer to fifth intercostal space. Index marker from 11 o'clock position, we rotate it to 90 degree. That goes to 2 o'clock position. So index marker will remain at 2 o'clock position, but the position will change from left third intercostal space to left fifth intercostal space in the anterior axillary line. Is that clear? Once we do this, we are almost parallel for scanning the heart. And what do we get? We get 4-chamber view. Here is a point of interrogation. This is LV, this is LA, this is RA, this is RV. This is interventricular septum, this is lateral wall. And lateral wall has got a papillary muscle. This is mitral valve, AML, this is PML, this is LA. This is RV, this is RA. This is tricuspid septal leaflet, and this could be anterior leaflet or posterior leaflet, depending on what particular position we are in. So let's see it again. 4-chamber view, LV, LA, RA, RV, AML, PML, lateral papillary muscle, septal tricuspid valve leaflet, or this could be anterior or posterior tricuspid valve leaflet, depending on our cut sections. What does this views tell you? Now the next question comes. Look, why we are scanning these particular views? Everybody has to be very sure. Why I'm doing all these kind of things? Why I can't do without them? Well, these views are very important for what? In parallel short axis view, we calculated pulmonic flow velocity. Look, this is the only view, parallel short axis view at aorta, we can calculate the pulmonic flow velocity. Similarly, in apical window are the only views where we can calculate aortic and mitral flow velocity. Here in 4-chamber view, we can look at aortic, we can look at mitral, we can look at aortic flow velocity. Not only this, these views are helpful for calculating the wall thickening abnormalities corresponding to coronary artery disease. This is known as septum. This is known as lateral wall. This septum is divided into 3 parts: apical septum, mid septum, and the basal septum. Lateral wall is divided to apical lateral, mid lateral, and a basal lateral wall. And if you look at a coronary artery supply of these 4-chamber view is, mid and basal septum is supplied by RCA. Apical septum is supplied by LAD. Apical lateral wall is supplied by LAD. and mid and basal lateral wall is supplied by circumflex. So practically all three coronary arteries are seen in this apical four-chamber view. On the other hand, we see RV free wall. RV free wall is supplied, all of you understand the RV free wall is supplied by RCA. The RCA branch supplies the RV free wall. And here we can look at the right coronary artery blood supply. So what we are looking at RCA, we are looking for LAD, and then we are looking for circumflex. Now, from 2 o'clock position, now counterclock rotation of a transducer. The position remains same. We are just parallel to the heart. And now our index marker is going from 3 o'clock position or 2 o'clock position back to 12 o'clock positions. As we rotate counterclockwise back to 12 o'clock position, this becomes anterior wall, this becomes inferior wall. And this inferior wall again has got a papillary muscle. So as we said in the beginning, there are two papillary muscles. One is attached to posterolateral wall, second attached to infromedial wall. Now here, this is whole is anterior wall, this is whole is inferior wall. And this inferior wall is divided to basal, mid and apical inferior wall. And this similarly, the anterior wall is divided to apical, mid and basal anterior wall. Whole of this anterior wall is supplied by LAD. Apical inferior wall is supplied by LAD. Mid and basal inferior wall is supplied by RCA. In two-chamber view, we look whole of the practically virtually LAD territories. And here it helps us a lot to differentiate what kind of a LAD lesion is. And in this view, if you have involvement of inferior wall along with right RV free wall, then we can be sure that we are dealing with right coronary artery. We move further. Now we have counterclockwise rotated further. And this image has become virtually same at 11 o'clock position. And in this 11 o'clock position this is anterior septum, this is posterior wall. And here's the aorta. Since aorta is there, we call them as three-chamber view or apical long axis view. What does it mean by? This anterior septum has got two segments, basal and mid anterior septum, mid and basal posterior wall. And this is the same anterior septum which we saw in Psax window. Only fact is, this image is identical of parasternal long axis view. But this is in fifth intercostal space, at left intercostal space, and that was in left second intercostal space. There we were not able to see apex, but here we are able to see apex. But the segmental wall motion abnormalities remain the same. This is basal anterior septum, this is mid anterior septum, this is basal posterior wall, this is mid posterior. Now again, in this particular view, we can look at the aortic flow velocity. And this is aortic valve. Before the aortic valve is LVOT area. And this is aortic valve. So we can look at the aortic flow velocity in this particular area. Next comes 5 intercostal space, left apical 5 chamber view. What is this 5 chamber view is? When the footprints start looking towards aorta, the aorta opens up. Now this is again a contention point. I'll go back and repeat again for all of you is, look, this is a transducer in left fifth intercostal space. Index marker is over here. And I'm almost parallel to the heart. It looks to be perpendicular, but I'm almost parallel to the heart. So what I'll drive 4-chamber view. If I tilt this transducer, the footprint is start looking towards aorta. So that footprint is looking toward aorta. I'm opening a 5th chamber view. If I rotate this index marker to 12 o'clock position, from here, if I rotate transducer to 12 o'clock position, it becomes 2-chamber view. And if this index marker again becomes at 11 o'clock position, virtually like a Psax window, then I'm looking at apical 3-chamber. So all 4 windows, if I have to comprise again, parallel window, that is 4-chamber view, 2-chamber view, 3-chamber view, and the 5-chamber view. They are derived in apical window. So these 4 windows help us in assessing the coronary artery supply of the heart, the most important part to talk of a wall motion abnormality or wall thickening abnormalities in patients. Then comes subcostal window. Here the patient lies flat on his back, legs folded, and we look at a subcostal view. In subcostal window, the index marker is back at 3 o'clock position, and again we are parallel to the heart. Slightly towards right shoulder, the transducer is facing the right shoulder. What do we get? We get RV free wall. Here is a RV free wall. Here is a RV. Here is a RA, and here is a tricuspid wall. If I rotate this transducer 90 degree counterclockwise, what I'm going to get is IVC view. In previous view, we again can look for a tricuspid regurgitation jet gradients. And once we rotate counterclockwise, index marker from 3 to 1 o'clock position, I drive IVC. And this IVC has got a lot of value, as we used to see JVP in our clinical practice. We see IVC in our echocardiography. JVP used to tell us normal or reduced. Here IVC tell you the relatively RA pressures. If my IVC is normal size, normal is up to 20. With inspiration collapses more than 50%, my RA pressures are normal, that is 5 millimeters a month. If IVC is normal in size, collapses less than 50%, my RA pressures are 10. If my IVC is bigger in size, more than 20 millimeters, collapses less than 50%, my RA pressure again 10. And if my IVC is dilated, does not collapse, which is known as IVC plethora, RA pressures are 15 millimeters a month. We'll be coming back to them again and again in our future time. In some COPD patients, we can drive this particular window, subcostal window as short axis view. And this is a replica of parallel short axis view at aorta. Virtually the aorta in the center and the pulmonic artery wraps around in this particular aorta. So in COPD patients, we can have this window in subcostal window. We can look at IVC hepatic junctions. We'll come over it over a period of time. When we have pulmonary embolisms, when we have a raised PA pressure, we can look at a dilated hepatic veins. And we look at the pattern of hepatic venous flow to the heart and decide about their flow. Now comes very lesser used window, right parasternal window. I'll just expose you to this. Right second intercostal space, and this is exclusively used for aortic valve gradients. Then comes suprasternal window. What is this suprasternal window? Is patient is lying flat on his back. Now legs have straightened up. Neck has been extended. Index marker at 1 o'clock position, and we are in suprasternal fossa. And once we put almost perpendicular in suprasternal window, what we get? We get ascending aorta, arch of aorta, and a descending aorta. And we can see 3 cranial vessels, left subclavian, left common carotid, and innominate in this suprasternal window. It has got tons of a value again. What's tons of the value? It can tell you of the aortic stenotic gradients. It can tell you about coarctation of aorta, because this is the only window where we can look for descending aorta. And then it can tell you about severity of aortic regurg. If there's a holodiastolic reversal of flow in descending aorta, we can really look at the holodiastolic reversal to talk about severe AR. So this is one window which really helps you a lot in assessing many things, as we could see color over here. I'm not going to talk about the colors today. We're going to talk about colors next week. So this tells you about suprasternal window, and many other windows which will come over a period of time will be discussed again and again. Hence to say that 2 dimensions echo is a backbone of echocardiography. All studies are done in reference to two-dimensional image today. Doppler and M-mode examination are obtained first, having a first reference from two dimensions. And most important magic word, ejection fraction. Like somebody, if you talk of echo, he says what? What is the ejection fraction? But I can assure you, by the time you will finish your course, the ejection fraction plays only a minuscule part of day-to-day's echo programs. Next comes the segments of 16 segment model of ejection fractions. Here is 4-chamber view, here is 2-chamber view, here is a 3-chamber view. 4-chamber view, I said mid and basal septum, RCA. Apical septum, LED. Apical lateral wall, LED. Mid and basal lateral wall, circumflex. 2-chamber view, whole of the LED anterior wall is supplied by LED. Apical inferior supplied by LED. Mid and inferior supplied by mid and basal inferior supplied by RCA. In 3-chamber view, mid anterior septum and basal anterior septum supplied by LED. Mid and basal posterior wall is supplied by circumflex. And that's how we look at 16 segment model in echocardiography. Many of you must be taught about 17 segment model. I'm not going to touch at this present moment, not to make you confused to a large extent. Next comes ejection fraction. As per guidelines 2015, anything more than 52 is considered normal in males and more than 54 is considered in female. But there's a World Alliance of Society of Echocardiography, which has recently recommended about 2 years down the line, ejection fraction in male should be 57 or more and female should be 58 or more. So, but till this get into the guidelines, obviously, we have to follow this guidelines of American Society of Echocardiography of 52 and 54 as the baselines of echocardiography. Sometimes we have got a very poor pictures of echocardiography. What this poor picture is, we cannot look at the endocardium. What we use myocardial contrast echo to look at endocardium. This is a very novel model where what exactly happens? We inject a microbubbles of albumin filled perfluoropropanes. They have a diameter of less than 6 micron in size. Once injected on the right side in the arm, they bypass the lung circulation and comes and opacify the left ventricle. Look, we injected these molecules in the right ventricle, and over a period of time, they have come and opacified the left ventricle. So whenever we have a poor echo windows, we use these molecules to assess the wall motion abnormality. And you can see very well when the contrast is there inside versus when the contrast is not there inside. That's what alveopacifcation from 3 dimensions echo. This is another module of 3 dimensions echo, which I showed you a couple of minutes back. Then this kind of a 3-dimension multiplanar can give you online ejection fractions, online volumes, and shortening heart rate and a cardiac output. And this 3-dimension ejection fractions can give you end-diastolic volume and systolic volume and the synchronicity with which all segments are they contracting at the same time or not. This is just to expose you. This is not at your level to talk in basic courses. Last but not the least, there's a word known as Myocardial Performance Index, which we'll be repeating when we'll be talking about systolic functions. This is an index marker which is not dominated by or dictated by preload and afterloads, or what we call them as loading conditions. What we call is Myocardial Performance Index, A minus B divided by B. What is A? A is a time interval between mitral closure and mitral opening. So we call them as MVCO. B is what? The ejection time across LV outflow. So A minus B, there is mitral valve closing and opening time minus LVOT outflow tract time divided by LV outflow tract time. That gives you a myocardial performance index. and anything more than 40 is considered as normal. The catch point is, as our LV function deteriorates, the myocardial performance index number will go up like 0.4, it will go up to 0.6, 0.8. It should be less than 0.4 to consider as normal. Finally, I like to close this session over here and take up the questions of anybody who is present over here. I'll stop my presentation, and with this presentation, I'll stop my recording too, which I'll be able to pass it on to everybody present over here.